I'm Sandy Lamb, the Division Chief of Pediatric Neurosurgery here at Lurie Children's Hospital, where we have a nationally ranked program in neuroscience.
I'm Jeffrey Raskin, Director of Pediatric Functional Neurosurgery, an epilepsy surgeon, and Associate Vice Chair of the Quality and Safety in the Department of Surgery.
1 in 26 people have a seizure in their lifetime. A seizure occurs when there is a sudden, uncontrolled burst of electrical activity in the brain. People receive the diagnosis of epilepsy when they have seizures that happen over and over. Many people with epilepsy can have their seizures treated with anti-seizure medications. However, not all people with epilepsy respond to these medications over time. Medications can also have side effects. Continued seizures are bad for the health and safety of children and can interfere with brain development and learning. Seizures are often unpredictable, and this makes planning life difficult. The quality of life for the whole family becomes affected. The staff at Lurie Children's Comprehensive Pediatric Epilepsy Center can help control seizures using a variety of methods.
Our team has pediatric subspecialists, including epileptologists, neurosurgeons, neuroradiologists, neuropsychologists, nurse practitioners, social workers, and more. These pediatric subspecialists meet weekly to discuss each patient and provide the best possible care. If seizures are not stopped with medications, other options include medical diets like the ketogenic diet and surgery. Surgery is safe and effective for many kinds of seizures. Seizures often come from sick areas of brain that disrupt the function of the other normal parts of the brain. Surgical strategies involve removing, disconnecting, heating, or electrically stimulating those bad areas of brain which cause seizures. Modern neurosurgery is safe, and all of the surgeries are more effective at controlling seizures than continuing medications that aren't working. Patients with better controlled seizures also have much higher quality of life and live longer than patients who continue having seizures on medications alone.
The specific type of surgery selected is based on factors that are unique to each person. When it is obvious where the seizures are coming from, such as a tumor or lesion in the brain, doctors can offer a direct approach to removing that part that is causing the seizures. On the other hand, when seizures are coming from many parts of the brain, or from both the right and left sides of the brain, surgery to remove something does not make sense. Sometimes it is necessary to get more information to locate exactly where seizures are coming from in the brain. A way to get this information is called phase 2 intracranial monitoring. Subdural grids or stereo EEG, stereo electroencephalography, are types of phase 2 intracranial monitoring. Candidates for SEEG can be people who have epilepsy with unclear or different findings from the workup studies such as MRI, PET, MEG, EEG, and more.
Stereo EEG is a safe procedure where temporary electrodes are placed into the brain. The epilepsy team may adjust the patient's epilepsy medications and sleep schedule to help record seizures. It is important to record enough information about the seizure so that we can develop a plan. The stereo EEG electrodes allow us to map important neurological functions like language and movement. If the sick areas of brain causing seizures are also areas of the brain that are important in language or movement, then removal is usually not recommended. In those circumstances, neurostimulation is the recommended surgical strategy.
Neurostimulation is the changing of neurological function using electricity, and it involves using small computers and electrodes to essentially help tell the sick brain to calm down or to stop seizures before they start. One such stimulator can be placed around the vagus nerve in the neck to give signals to the whole brain. Another type of stimulator called deep brain stimulator, DBS, or responsive neurostimulator, RNS, can be placed in a deep brain location like the thalamus. DBS acts like a pacemaker for the brain, stimulating at very regular intervals. RNS acts like a defibrillator for the brain, mostly sensing for seizure activity and then stimulating the brain in response to make the seizure stop. The evidence supporting the use of DBS and RNS in children is equal for controlling seizures.
Neurosurgical planning is done using tests like brain MRI. For responsive neurostimulators, or RNS, the neurostimulator will learn with its small computer recording from the brain electrodes when a seizure is going to happen, and then deliver electrical current to try to help stop a seizure before it starts. This technology helps people with epilepsy and gives hope for seizure control in ways that were previously not possible.